So firstly, I'd like to thank the Kin International Awards for having me and for speaking this evening about a case of a patient that I've seen in the National Coagulation Centre in Dublin. So my name is Jessica. I'm one of the dentists that works in special care dentistry in Dublin in Ireland. So this case is about a personalised multidisciplinary intervention to reduce gum bleeding in a patient that has severe type 3 von Willebrand's disease. So firstly, I'm just going to talk a little bit about sort of women with bleeding disorders. So women with inherited bleeding disorders experience a significant challenge in their health and personal and reproductive lives. They have symptoms which can present in childhood or adolescence, and quite often there can be significant delays to getting diagnosis. So they experience things like easy bruising, epistaxis, bleeding from minor wounds, bleeding from the oral cavity, bleeding following dental work, surgery, and they can even suffer from gynecologic and obstetric bleeding. Quite often the most common sign would be heavy menstrual bleeding, and about 30% of all women will have trouble with this. About half of those women will have to seek medical care, and about 15 to 30% of those cases will actually have an underlying inherited bleeding disorder. This doesn't even just affect the woman, it can affect sort of partners of women as well, as the impact of having or being a carrier of a genetic disorder can cause significant psychological distress, particularly if they're embarking on a pregnancy. So these sort of symptoms can greatly reduce the quality of life for these women. They can cause many of them to have sort of social embarrassment, self-consciousness, and quite often they'll even miss sort of school or work due to the severity of the symptoms. Quite often many of these women are left undiagnosed and don't have any access to appropriate medical care as their symptoms aren't recognised as abnormal. And other challenges with diagnosis can be with lab testing or classification of their bleeding disorder. So we really need some education and training to the caregivers. The multidisciplinary approach is sort of crucial for sort of the correct management of these patients, either in managing the bleeding itself or planning in advance of any surgery. So my case in particular was about a patient that had von Willebrand's disease. So von Willebrand's disease is actually the most common of all the inherited bleeding disorders, and about 1 in 1,000 people will have von Willebrand's disease. It affects both men and women, and it can range from mild to severe, with type 1 being the mildest and type 3 being the most severe. The case I'm going to talk about is a woman with type 3 von Willebrand's, and about 1 in a million people will have type 3, which is only about 5% of all the cases of von Willebrand's disease. So these patients can present to the dentist with some sort of unusual sort of signs or symptoms. They may bleed significantly following any surgery, root debridement, even extractions. So quite often the dental team might actually be involved in sort of signposting these people towards an early diagnosis. And in our case, it was a 24-year-old female. So she had severe type 3 von Willebrand's disease, and it was her hematologist who actually referred her to us. She was originally born in Guatemala and she'd moved to Ireland during her childhood. However, she'd been lost to sort of transition from the pediatric to adult dental services. So their concern was that she was waking up with large clots in her mouth. She was hemorrhaging onto her pillowcase. She was having spontaneous bleeding from her gums, and they were finding it very difficult to manage this. Whenever she was brushing her teeth, she was finding that she was sort of bleeding for hours afterwards. And these ongoing daily challenges weren't only affecting her sort of oral health, but her emotional state, her intimate relationships, and even the burden of the poor oral health was affecting her quality of life as well. She was finding it difficult to find work, and she was smoking about 20 cigarettes a week just to manage the stress of everything at the stage. So on her first visit, we got her to fill out one of these questionnaires. So it's quality of life and health belief questionnaire. And it indicated to us that she's sort of having quite a lot of challenges in her daily life, having to alter food choices. She's feeling quite tense and embarrassed about her oral health, and she's generally just finding life a bit less satisfying. She feels like she's going to experience bleeding gums for a long time. She didn't feel in control, and she thought that only her prophylactic medication, which she takes for her bleeding disorder, was the cure for her bleeding gums. She thought that only once the bleeding had started, little could be done, and this is how she was going to experience for the rest of her life. We also then, on her first visit, used another tool called the Quigley-Hine Index, which is just shown there. And it can help identify plaque, and it helps in this case with the patient as an education tool to show that the plaque can actually be the cause of the bleeding and it's not actually linked with her bleeding disorder. So her initial presentation, she sort of had very erythematous and inflamed gums. There was generalized sort of flattening of the interdental papilla, and there was quite a lot of bleeding on probing, particularly in the upper premolars and lower incisor area. On that first visit, it was more an introduction to the patient, doing some oral hygiene instruction, and even after the examination, there was quite a bit of bleeding from the gums. So this was controlled chairside using some topical tranexamic acid gel or Exagel, and some local pressure. We did do her Quigley-Hine index on that visit, and her plaque score was high. It was a 2.67, and it showed the sort of pattern where she was missing. It was along the gum line. We took an OPG on this visit as well, and it confirmed that she had sort of early stage periodontal disease, and there was also subgingival calculus. So following that, we went into the treatment planning stage, and this was mainly guided by the questionnaire results. It highlighted to us the sort of need to re-educate her on her oral hygiene techniques and explain sort of gingivitis and periodontitis to her. Patients with the bleeding disorders can get quite a lot of conflicting messages growing up, and so motivation and positive reinforcement would be sort of a key role for her in the management. Healthy gums don't bleed, even in patients with severe bleeding disorders, and quite often medical teams and families can perpetuate the belief that the bleeding is linked to their bleeding disorder. So they're advised not to carry out normal interdental cleaning, advised to use soft toothbrushes and mouthwashes, which obviously, as we know, will just end up causing more plaque accumulation, causing further inflammation, and then actually aggravate the bleeding and make it bleed more profusely. So in her case, a personalised preventative oral health education and supportive therapy programme was decided on. So we gave her a home care routine tailored to her bleeding disorder, and we devised it using sort of a three-pronged approach. So there's education, skills acquisition, and motivational approaches to help with her behaviour change and for goal setting. Our education was mainly centred on addressing her beliefs about the causes of gum bleeding. So the plaque disclosing tablets we used in surgery on her first visit, and we also give them to her for home, and it helps her to see sort of where the inflammation is caused. It allows her to carefully remove the plaque along the gum line, causing minimal trauma, and remove the fear of indiscriminate brushing. She was encouraged to use a medium brush instead of a soft brush and use some TP brushes for interdental cleaning, which allowed for more effective plaque removal, and she was specifically given permission to brush in the presence of bleeding, which she'd never done in the past, and encouraged to continue brushing thoroughly and systematically even when the gums were bleeding during the process. We advised her to use some tranexamic acid gel, which is the Exagel, to help address bleeding at home, and we provided her with some motivational support in between visits through teledentistry, which helps remind her of her goal, which is to be able to wake up without blood in her pillow, to be able to go out and eat in public without fear of bleeding. Prevention really is key in this sort of group of patients, and regular checkups are important because it allows us to sort of prevent perio disease, help with early diagnosis or treat it non-surgically in early cases. We want to avoid sort of bleeding complications or the need for invasive treatment, such as periodontal surgery or exodontia, as these will require prophylaxis. However, when required in these situations, the haematologist should always be consulted an appropriate prophylactic regime to prevent secondary local bleeding during the intervention, and then the dentist can carry out treatment using any extra local measures required. So on her first treatment visit, she had reattended to begin treatment a few weeks later, and even following just oral hygiene instruction alone, she'd improved her plaque score down to a 1.67, but just 2 weeks later. So invasive route debridement was carried out under local anaesthetic. We carried out over 2 visits with ultrasonic and hand instruments. Ideally, it would have been done over 4 visits, but due to the cost of the prophylaxis every time she attends, it was decided over just doing it 2 visits, so right and left. The patient did need some sort of prophy in consultation with her coagulation team. So she had Willebrand, which is a combination of von Willebrand factor and factor 8, and she had that pre-operatively before any scaling was carried out, and was needed to be given 1 hour before treatment. Then we used systemic and topical antifibrinolytic therapy following the procedure. But she was given a number of kin products to use during. So after each treatment visit, she was provided with some kin gingival complex 0.12% mouthwash, and she was advised to use this twice daily for 2 weeks following the appointments. We also did have to use some periokin hyaluronic gel in the deeper, more residual pockets, particularly those upper premolar and lower incisor areas. And we used the kin exogel to control bleeding in surgery, and the patient used it at home as well. Her second treatment visit, again, there was great improvement in the plaque control. So her plaque score was down to 0.8 on the Berkeley-Hein index. And she was delighted to tell us in this appointment that following smoking cessation advice, she had stopped smoking all of her own accord without the need of any nicotine replacement therapies. So really the outcome basically of this case and why sort of it was so beneficial was a 3-month review. She had no spontaneous bleeding from her mouth. She stated her gums were no longer affecting her emotional well-being, and she was a lot more optimistic. She believed her gum condition was now treatable and not linked to her bleeding disorder. She'd even been able to go out and buy a new white silk pillowcase. As she said, she hadn't woken up with any blood in her pillow for over 2 months. She also filled out the quality of life questionnaire again on the 3rd visit, and that sort of highlighted the key improvements in this case. There was some notable plaque still on this visit, so we did reinforce some oral hygiene instruction, but we were able to carry out a simple supragingival ultrasonic scale. And main key factor from this is we didn't need any systemic medical intervention to address any bleeding on this visit. So the questionnaire results really highlighted the positive changes in her new knowledge. So in her first visit, she said the 3 things which she thought made her gums bleed were brushing, flossing, and eating. And now on this visit, she said the 3 things which make her gum bleed were not flossing, not brushing, and smoking. So she stated that the gums were no longer affecting her emotionally, and she'd become a lot more optimistic, and she'd become more positive about dental treatment in general, and her attendance appointments have become very good. And she was aware of the benefits of dental treatment and the effects it can have on her gum health, and it wasn't just her medication. So main outcome, we felt this case was quite important because it does address the commonly held myth that bleeding gums in patients with bleeding disorders is caused by the disorder rather than underlying gingival inflammation. The recent global burden of disease study did show that periodontitis is the 6th most prevalent disease worldwide at 11.2%. It's quite silent nature of the early stages of the disease combined with sort of poor awareness can lead to many patients only seeking symptom-driven care at the advanced stages, which can be particularly difficult to manage in these patients where the bleeding has such a profound effect. So patients with severe von Willebrand's type 3 disease do face a huge detriment to their quality of life. If there's poorly controlled periodontal disease, it can cause them pain, stress, it can affect their eating, negatively impact their socializing, self-esteem, and even sleep. So it is really, crucial to have optimal gum health. And this is through a partnership between dentists, patients, and their hematology team. Everyone needs to know what role they have in their services available, and the message needs to be shared across, so patients aren't getting conflicting messages. So moving forward, her medical team, she sees them regularly anyway, and they're going to help nudge her regarding her oral health measures and the importance of regular visits with her dentist. The medical team will be motivated by sort of the significant improvements in her quality of life, her increased hemoglobin levels, and for them, it's a benefit not having to use thousands of euros of factor replacement for every dental visit, as at least now her gingival condition is stable. And just moving forward, I think in general, it might be useful to have an education program for dentists and hygienists who might generally be fearful of sort of treating these patients with bleeding disorders. And it could be beneficial so these patients get the same care as everyone else, and they're not left sort of delayed for long periods of time where their periodontal condition just gets worse and worse. And then there's just a couple of websites here if anyone's sort of interested in reading any more about sort of bleeding disorders, and particularly just women, because they're quite commonly undiagnosed compared to men. Thanks very much for listening.
Okay, so I was saying that Dr. Jessica Monaghan is bachelor's degree in dentistry with distinction in orthodontics in Queen's University Belfast School of Dentistry in Ireland, and she's currently working for the Dublin Dental Hospital in a special care role and treating medical complex patients. The case of Jessica Monaghan will be moderated by Dr. Olivier Carquac and Dr. Josenar, so the floor is yours.
Thank
Olivier,
you.
you want to start?
Yes. Yeah. I would like, Jessica, first of all, to congratulate you for this presentation, for the award, and to have submitted this, one of the best clinical case. And you really demonstrated to us the great management of a challenging case, probably not from a periodontal perspective, but definitely from a medical one. Yeah. And I think that you address this perfectly, and you make it very, very clear that more than periodontal treatment, very, very often it's very much about informing the patient, having the patient aware of the situation, having the patient aware of how to understand the disease, how to take care of the disease. And I think that you did it very, very clearly for all of us here, and this brilliant. That's what we usually call as cognitive behavioral therapy, and that was great. I will just have one question to you, Jessica. It's now, considering the audience which are listening to you today, this evening, would you recommend colleagues to take care of such patient with this medical background, or to refer them in specialist care? We don't hear you, Jessica.
Sorry. So in Ireland now, Dr. Allison Dougall, the consultant I work with, she sort of devised like an information sheet for dentists. So it sort of summarizes treatments that are safe to do in practice. So sort of fillings, crowns, root canals, and things that require an ID block, or maybe if patients who need an extraction or some root development can come into the hospital. But certainly some of the patients that have quite a mild bleeding disorder can be treated in practice with just sort of oral antifibrinolytics, so tranexamic acid tablets. So it's always worth speaking with their hematological team, but quite often some of the more milder cases can have most of their dental care carried out in practice, although it seems a scary thought initially. You know, it can be a lot more efficient for them trying to get in for appointments. Some of them are having to travel great distances to get up to Dublin, you know, from other ends of Ireland. So if they can get sort of most of their dental treatment done locally, it's a lot better for them as well.
Great. But I guess that the patient was very much aware of a condition when she met you, right?
Yeah, luckily she knew about her condition, but unfortunately she wasn't really, she thought, you know, all of her problems were from the condition. And it was just, really a missing link with education at some stage.
Yeah. Jose, do you have any comments?
Sure. Thank you, Olivier. First of all, as you said, Olivier, I'm you know, like to congratulate Jessica. I have to say, Jessica, that I was quite surprised that your case was selected as one of the finalists. But I'm very happy. I'm a periodontist as well as Olivier is, and you know, without mentioning it, you've described perfectly well the step one of periodontal therapy: information provided to patient, behavioral changes, supragingival debridement in different appointments, as the patient is getting motivation and is seeing and is realizing the changes, you know, just controlling the plaque biofilm and the supragingival debridement is you know, happening, is generating in the mouth. They're getting more motivation, and you're giving them time to assess the plaque control and to get improvements 1 week after. So you described very well the step one of therapy. It is so important, you know. Olivier and I enjoy doing gingival grafts and placing implants and achieving, you know, very nice aesthetic outcomes. But I'm sure both of us give more importance to the step one of therapy that you have described so well. And there is no clinical success whatsoever without the first step one of therapy. So I'm so glad we started with your case. I'm so glad you're young, but you describe it so well, and you spend time with something that for many clinicians seems to be boring, but it is not. It is the main therapy. And my congratulations. The only thing I could say is just look at Olivier pictures in his Instagram account, and you'll be pushed to buy a new camera. Okay, that's the only thing you can do. But keep working with that excellence, informing patients and changing their behaviors. Okay, because this is what it's all about. Okay, congratulations.
Thank you.
Can I just have time to ask just a last question to you, Jessica? I understood from the case that, I mean, regarding the PSR, you had as maximum like 5.5 millimeter pockets on the molar area, right?
Yeah.
Yeah. And that means that obviously you could manage this case non-surgically. If you would have considered a surgical approach, what would have been your management in this case?
So for this case, she might have needed more prophylaxis. So she receives sort of 3,000 units whenever she has her normal treatment, but because it would be requiring a little bit extra cover, she might need more for Wiley, which is the type of treatment she gets. So would speak to the hematological team, and they can just boost basically her levels a bit higher in order to be able to provide enough cover to be able to do the treatment safely without obviously post-operative hemorrhage or trouble a couple of days later.
Okay. Okay, thank you. So I understand that the communication with the hematologist was paramount, yeah?
Yeah, absolutely.
Jessica, if you allow me, let's say this patient would have, 7 or 8 millimeter pockets in the posterior sextans. Is it worth going for surgery? Would you go? Is the patient a candidate for periodontal surgery?
Yeah, as long as she was motivated enough, absolutely, and she was able to maintain it afterwards. Ideally, you don't want to have to do extractions either, so it's really just, I suppose, weighing up the risk and what she wants, what she can manage. She was quite motivated now, and she feels quite positive about dental treatment, so there's nothing to say that she couldn't moving forward if she did need it, but hopefully it won't get to that stage.
So medically, it was fine to go for it.
Yeah.
Thank you so much. Thank you.
Thank you.
Okay, thank you very much, you all, and you especially, Jessica.
Hello, my name is Jessica Monaghan. I am a dentist currently working in Dublin in Ireland. I work in the National Coagulation Centre in St James's Hospital. I recently participated in the KIN 2021 awards, and I was one of the top 5 finalists. The reason I decided to enter the KIN awards this year is that we use quite a number of KIN products for our patients in the Coagulation Centre. Our patients have sort of ongoing lifelong challenges with gingival bleeding, and I wanted to highlight this, which is why I selected my case. I felt like KIN awards were a great platform to raise awareness for particular cases, to see other amazing works that are going on across the world, and it was a great opportunity to work alongside some very highly acclaimed people, and I would definitely recommend it. Thank you.